Good afternoon. We're about to begin the afternoon session of the October 24th conference, the Carcinoid Neuroendocrine Tumor Society of Canada conference. And the next speaker is Dr. Tom O'Dorisio. Thank you.
There we go, good. Just a comment about these slides. You may or may not know two things, actually. This is a pretty much new talk, and I have a habit when there are new talks I don't think I'll run over this one, but I'm always a little insecure, so your general comments will be very important to me. And you may remember Irma La Douce. I think you remember the movie with Jack Lemmon and Shirley MacLaine. Some of you may be. And you remember when Jack Lemmon was telling Irma, he said, he was in a conflict situation and there was an explosion. And then he said to Irma, please be gentle with me. And so I said, oh, that's interesting. I'll ask the audience, please be gentle, because this is a little rough on the edges here. But what I'd like to do now is share the schema again. And there are no colored boxes because every one of those boxes is an option of care or a decision-making track or a box wherein a decision can be made. This morning we talked about the pathology of tissue diagnosis and the peptide radioreceptor or the peptide radioimmunoassays. We now can measure the somatostatin receptor subtype 2 lock, if you will. We can measure that. It's like a fingerprint for people. Because if the OctreoScan can't see the tumor, then you'll always wonder, do I have the receptors? And now we can do it in a histologic level. Dr. Oberg was one of the first to pioneer the SST2 receptors with the development of his antibodies. And Dr. Sue and I have had our antibody that we developed for the last 10 years ago, which is also a very good one, but it also can be used from a tissue block. You just take it from the block of tissue that's in paraffin wax, and you can know if you have receptors on them. It's not commercially available. I doubt it can ever be because the antibody supply for the receptors in the United States, the American College of Pathologists require that there's a commonality of the antibody so that if it goes commercially used, that there's a common supply of the characterized antibody. So I don't know when or if it will ever come as a commercial test done by histochemists. But every one of those boxes are an option, and that includes surgery at the top left. I've put it together this way, and obviously somatostatin congeners, we've heard already today, the PROMID study, I'll mention it at the very end. There's hepatic arterial chemoembolization on your sheet. There's clinical trials with the Anti-Angiogenics. There's liver transplant, hopefully someday with a little bit better criteria allowed by the national organ donor group, because right now it's very difficult to argue for a liver transplant in folks suffering extensive involvement of their liver. There's chemotherapy, and there's peptide radioreceptor therapy being done in at least 5 centers in Europe. And many of the folks from Canada are eligible to go to England, we're told, John Boscombe's program there. But a good option at the wrong time may not be the best option. And this is what I'm going to share with you over the next few minutes. I'll just give you the other blade, the other side of the sword. And these are the things that you really need to work with a coordinating person for. The first lecturer this morning spoke about the primary care, and I've heard today we have to get primary care physician involvement. I must tell you, though, at this moment in time and over the last 10 years, 85% of all the 1,300 folk I look after on a regular basis come from medical oncologists. The way I close that loop is the first question I ask him is, who's your primary care? I then sit down and write a letter to the doc and say, I had the great pleasure of meeting, and this is where we are. And I would like to ask your help and support in obtaining a CT scan and getting the peptide markers and telling them how to do it. And the primary care docs will do everything in their power to do that. And the medical oncologists, for the most part, have not bought into completely their very prominent role. And that's why I think they come to an orchestrator or an organizer or whatever you want to call me. But that's how it works for my clinic in the United States. So just to say that, I think the primary care people, we've had some diagnoses made with being very alert. But for the most part, these are folks that have had surgery for it and then go see an oncologist immediately, and then the oncologist brings it forward, at least for one visit or more, hopefully. This is a great slide by Arthur Vinnick. You've seen it many times. We heard a little bit about the SEER data. And if we all stood on a mountaintop and we looked and said, what is the natural history of carcinoid? Or what is the natural history of neuroendocrine tumors? Look at it better that way. I find myself going back to the carcinoid terminology again. You'll see that it grows at time 0 for 7 to 9 years. They estimate a 7.5-year incubation time or growing time. And it's a good news, bad news. The good news is your own body's natural hormone, somatostatin, the one that God nature made for us, has been protecting the growth, has been protecting the tumor and making it grow slower over time. And that's because of the somatostatin receptor on the tumor, and that's because we have our own body's hormone called somatostatin. It was no accident that Sandoz named it Sandostatin because it sounded so much like somatostatin. But then what happens, it starts to grow, and then when it goes to the liver at about 12 years or so, there starts to become the complex. I call it carcinoid complex because few of my folks, fortunately, in this day and age, have liver or have heart valve, right heart valve involvement. So for me, it's really not the true syndrome, it's the complex. Although some would say it's really the same thing. And there's usually different expressions, but flushing is always one for the true carcinoid tumor of the midgut. Perspiration I find very significant and very prevalent in folks that are symptomatic at nighttime. And if you think about that in non-REM sleep and you start thinking dreams that raise your adrenaline, anything that raises your adrenaline turns on, squeezes serotonin from a midgut carcinoid like a grape. So the 5 E's that you all know by heart as exercise, emotion, excitement, ethanol, a glass of wine can sometimes trigger their flush in a minute. And people always get offended. I said, well, do you drink wine? I haven't touched a drop in 2 minutes, I said, no, it's okay. But I just want to know, does it cause a flush right away? And they said, well, yeah, it triggers it within a minute or two. Jerome Feldman used to make his career at Duke University. He called it the Jerome Feldman port wine test. He'd pour an exact glass of 2 or 3 ounces of port, and then he'd start the watch, and he'd have them drink, and then he'd time it to the flush, and that's how he could tell if they were, subclinically symptomatic with it. But be that as it may, our goal is not to show this natural course so much as to say we come off the course with the exercise of the options. So as we exercise the right option at the right time, hopefully for you, you come off that curve. You drive the curve back. You're pulling the clock backward, and you're taking it off of a line right here. You're moving it from this predicted natural course. And we saw some great information already that was summarized this morning, just showing you the impact of octreotide since it came, at least in the United States, in 1989. It's had a tremendous impact on overall survival. But that's just one option, which is always the number one for me. And then there's surgery and just debulking and cytoreductive surgery. We've heard about that today too. And we've seen how you can leave a little margin of tumor. It's okay. But you've done something. You've taken out the factory. These are not dumb tumors. These are tumors that may make hormones. They're probably making substances that we haven't even measured yet. But the bottom line is each one is a little trickle that goes into the big stream. So if you can remove the factories, you're doing a tremendous amount for yourself, for quality of life for sure, if it's a syndrome, or for the very fact that the tumor now has to grow back again, and it's a slow-growing tumor. So that's a therapy, okay? That's therapeutic. Now, what are the therapeutic options? And we heard for the first time what was killing. And this is the way to look at the options on that schema. You have killing, which is surgery. You cut it out and you put it in a bottle and it's not there anymore. And then you also have hepatic embolization, which we heard some about. There's bland embolization where they exploit the hepatic arteries that we heard so well this morning from in terms of the perfusion of these tumors by the arteries. And you can use talc. You can use chemoembolization, which is talc dipped in chemotherapy. And now we have the Y90 glass beads, which are called Theraspheres, or the bio-non-degradable beads, which are called the Y90 Surspheres, which are used widely in the United States. Those kill where they target. So you are getting killing therapy there. And then we have the last thing we'll talk about before sandostatin again is the Y90 or the lutetium-177. We heard just a wonderful explanation of the isotopes this morning by Dr. Driedger. And we have those available again in Europe. The leading centers in Europe include Uppsala with Dr. Olberg, and Basel, Switzerland, and Erasmus, and Paganelli from Milan, and England, where you folks have access to that therapy with Y90. And chemotherapy at the right time. And I'll share a case of a person that was both very positive for OctreoScan and very highly PET positive and did well with both two therapies. Then we have static therapy. And this is the group that these are the treatments that now say, as it was always predicted by the oncologists, carcinoids are cancer in slow motion. These are the treatments now where we're given a static. We're given a tumor now that just stares back at you, doesn't function, and it just looks back at you and you live with it. And sandostatin is clearly, somatostatin congeners such as lanreotide and octreotide now are probably now shown to be very anti-proliferative. So they do slow progression. They're not just therapeutic. I mean, they're not just for symptomatic palliative care. They're actually anti-proliferative, but they don't kill. And the anti-angiogenic drugs, which are the newest thing, and I'll close second to last with that, are the ones that are now available. Two are off-label now, but available in the United States. One of them is Afinitor, which is everolimus, which is a cousin of the anti-liver rejection drugs, believe it or not, and they're very powerful activity on pancreatic neuroendocrine tumors as a stabilizer, as a static. It takes the tumor and holds it, just holds it at bay. And that's okay. It's a therapeutic option, and it's okay. And how you use it and when you use it is part of the decision-making tree. So just a word about surgery and tumor debulking. We heard an excellent discussion this morning from our surgeons, endocrine surgeons. Although it's true there are a few studies available, all have shown benefit with either primary tumor removal or tumor debulking for neuroendocrine tumors. Now, this is one that's a little more controversial. I tried to tease out this morning, and I learned something very important, and that was the decision on surgery really impacts an extensive pancreatic surgery if there's a lot of liver tumor involvement. They did not comment, nor do our surgeons comment, if it's a mid-gut carcinoid and there's a lot of tumor involvement. There does not seem to be a downside to a liver being damaged irreversibly, and that's what I meant by tipping over with the operation itself. But in general, we use a Doppler ultrasound, and we use a grayscale, and it's very clever because it's read by hand. A computer can't read this. It's a 20-minute procedure. And what happens is they measure normal liver with the Doppler, the blood flow, and then they estimate the size of the liver and estimate a % tumor burden. And it's been very, very helpful, and it's a very good way to do it. CT, MR, tumor volume measurements just are not good. They're very laborious to do, and you can't get them on a 6-month or a yearly basis. But you can get a Doppler ultrasound using the grayscale. They now have one with little bubbles that act like that are air bubbles that they put in. It's like you can look at the blood flow and they can say, is this a functional tumor or is it just a tumor staring back and non-functioning? So you can get enormous information, and we use that sometimes against the decision to do surgery if there looks like there's more than 60, more than like 75% they won't do. They tend not to want to take the primary out, and we're working with our people on that. But in general, that's a good way to estimate liver tumor burden. And as many of you know or should know, that the livers can, you can't estimate tumor volume by looking at a CT or an MR. When you actually do it by Doppler, you'd be very surprised. And the vast majority of the folks that come to me for the first time have less than 30% liver tumor burden. And that's by Doppler, and that's a good news kind of thing, because the thing we want to do is preserve the liver at all costs. Regarding hepatic arterial embolization and Y90 spheres, again, you have to try and determine the percent of liver tumor burden. And I was speaking with Dr. Ardell earlier, and I honestly feel that the pancreastatin level will be based on one paper, Bloomston, who published from the assay from Ohio State University. And in there they looked backward at their hepatic arterial chemoembolization successes, and they also measured the pancreastatin. We measured them back in 1997 forward, and one of the observations they made is when the pancreastatin level was greater than 5,000 on the OSU assay, which would be about 1,000 or 1,500 on the California assay, and I think Dr. Ardell's assay in Europe, in England, in Ireland is similar to ours, that there might be more morbidity with another embolization. So I used the radioimmunoassay of pancreastatin to recommend another therapy procedure, even though it's a lot of times driven home by the interventionalist. We must do this again. You have to be careful, because you can't go to the well too many times. There's no procedure in the embolization procedure that doesn't have some collateral damage, some normal hurt, a hurt to the normal liver. And we don't want to lose the normal. So and Y90 was touted as being less friendly kill. But the bottom line is they have to give, in order for the spheres to work, you have to give the Y90 way back at the widest opening of the artery. You can't slide it straight up because you can't get distribution of the spheres evenly. You got to start way down, and they can be damaged to the vessels on the way to the target. So we have to be very careful. And yes, we have seen liver damage, and the Doppler ultrasound can read a hepatocellular disease. And yes, we've had patients whose tumors are dead, but so is their liver. And that was because of repeated embolization procedures. When you cut a piece of liver out, it grows back. But when you do this kind of procedure on it, you get some of the harm. So you have to be careful on the number of times and how selective the embolization is. And those are decisions. Those are decisions that in terms of reducing tumor burden, that we have to worry about the other side of it, namely normal liver. Now here are the clinical trials, and these are the anti-angiogenics. And there was the N.E.T.C meeting, North American Neuroendocrine Tumor Society met a week or two ago, and there was some excellent abstracts that will be published in Pancreas as an open forum presentation, I think in February 2010. And I'm just going to show you two of the abstracts. They're a little word intense, and I don't pretend to be a pro in these. I have worked personally with everolimus in the pancreatic phase 2 studies that Novartis had, and I was aware of the Sutent sorafenib paper, pancreas study, and that's one I'm going to show you as well. But these are the static treatments. These could be, and this is why a medical oncologist is very wonderful at a certain point in time, because they can oversight embolization for you with the interventional therapist. They can also do off-label of these drugs that are now approved. 2 drugs are approved for renal cancer, and they both have very good activity for neuroendocrine tumors of the pancreas and neuroendocrine tumors of the midgut, especially afinitor or everolimus. And there's one other very good chemo kind of therapy for this type of tumor, and that's the first one I'm going to share with you now. This was by Larry Coles and Jonathan Strasberg from Tampa. But they're all in the clinical trial stage at this time in the United States. Sutent is particularly active on pancreatic neuroendocrine tumors. They stopped the study early in the United States because of its effectiveness in terms of progression-free survival time and overall survival. And everolimus is the one that's called Afinitor, and that's in phase 3 studies now for both midgut and for pancreatic neuroendocrine tumor. But they're static drugs. They don't kill. They can shrink and hold them down, but they're not killers. And one of the things we're finding out is a pancreastatin level before versus after treatment. A drop of pancreastatin of greater than 20%, and this is based on 4 papers, a pancreastatin decrease of 20% bodes extremely well for durability of the effectiveness of the drug. Now, this is the first paper, and this was the first-line treatment of metastatic pancreatic endocrine carcinomas with capecitabine, which is a 5-FU backbone, and temozolomide, Temodar. Now, I have no practice experience with temozolomide. The first person to really start talking about that was Matthew Kolke from Dana-Farber. And then Larry and he and Jonathan Strasberg started to look at this in pancreatic tumors. In general, and I alluded to this morning, and it's some of the neat work now that shows that the tumors of the pancreas have much more replete receptor subtype 2. And I think in general that's why there's been such good activity for the treatments with Y90 and lutetium. But the pancreatic neuroendocrine tumors have an ability to respond very well versus the midguts. And it may be because of some of the receptor populations, the locks on the tumors, that may be making a difference. But this is a pancreatic study. And it's all on your handout, and this is almost verbatim of the abstract. I tried to clean it up a little bit. But their purpose was to evaluate the efficacy of capecitabine and temozolomide in folks with metastatic endocrine carcinoma. These were pancreatic. They were assessing the response, which was the progression-free survival and the overall survival. And these were all metastatic, well-differentiated pancreatic endocrine carcinoma patients. So remember, these are one of the first 2 good types, the well-differentiated tumor, neuroendocrine tumor, well-differentiated neuroendocrine carcinoma. So those are the categories histologically that were eligible, not the class 3 small cell. That, again, is more probably, it's a different beast. And they were naive patients in terms of having chemotherapy, and that's the regimen that they were given. And the response rates were assessed by this RECIST criteria, which in largest part is based on changes of CT or MR, so CAT scan or magnetic resonance imaging. And the results, as you can see, 67% achieved objective responses. So that would be either complete response, CR, or partial response, PR, which is between 25 and 50% tumor reduction, or minimum response, which is 25% or less reduction, and stable disease, SD. Those are the ones that are put into a stable situation. And and their conclusion was that the combination is associated with exceptionally high durable response rates. So this is immediately now available, but it's off-label but it's another option. Would you put it first if you were to, versus surgery, if you could have surgery? I don't think so, but that's the kind of decision-making tree that a person who's aware of these things, the centers, I think, if you will, can offer you. They can offer you an algorithm, an option for you now versus later. And the ideal thing is not to throw an option out by using another option. Keep all your options open. And for the most part, the boxes that you see there are not irreversible options. And you'll see the arrows on my boxes are the boxes in practice. I'm not saying it's unique. I'm saying I put it together that way. But if you go to any of the centers, they all talk about pretty much the same therapeutic things. Now, this is the SUTENT study, and I won't belabor it, but this was in the abstract. It's going to be published. It came out of a large international group study. I think, if I remember, and Dr. Oberg, again, was very much involved in this study, too, in Uppsala, Sweden, as an investigator, and Arthur Vinnick in Virginia. And this one they closed. I hope they didn't close it too early. They closed this study because it was so effective. They actually closed the study down because it was effective. And that's, I've never been in part of anything like that happened. But at our university, Dr. Heft-Anderson's study was stopped, and we had about 6 or 7 folks being treated with it. Again, it's pancreatic tumors, again of the well-differentiated kind. And they had a placebo, and people were very nervous about a placebo, because when you're into a phase 3, you have to be very careful with placebos. Now, placebo means they got a sugar pill, but they also, or a pill that wasn't active, but they also got sandostatin with it, both arms. But once there was progression at 3 months, they were allowed to, and the code was broken, they were allowed to cross over to the active. And that's a good study. So when you tell somebody they're going to be randomized to a placebo arm or an active arm, they follow it very closely, and they're very strict. If there's a slight bit of progression, they break the code, and if you're not on the active drug, you can be on the active drug. And that's ethically okay, in my judgment. And again, this is the methods of it. You can read it. The endpoint was progression-free survival. And you can see that the amount of progression-free survival was about 11 months versus 5 months before they were offered the option in the placebo group to cross over. And it's very good clinical efficacy. So I'm saying this new classification of how do they work? I have just been babbling, but here's how it works. It stops the new blood vessels, not the ones that are already there, your ones that have been formed, but new blood vessels. These tumors draw or make new little blood vessels to supply the tumor. These choke those blood vessels off. So now if you take the root out, these tumors don't grow. They can't keep growing. They don't have a blood supply. That's the rationale for all of these that you're hearing about, antibodies and what have you. So the last thing is PRRT, and most of you know this. OctreoScan buys you the ticket for the PRRT.